So before Molly officially comes up and gives her lecture, I'm just going to give you a little bit of background about the James Flaherty lecture, and then also introduce Molly herself. So the Ireland Canada University Foundation is an organisation that's based in Ireland, and they have a number of different programs that they fund with the idea of obviously expanding the scholarly capacity of Ireland. And one of these is the James Flaherty program, which is an exchange program. And this is primarily to build networks of academics, linking Canada and Ireland, and then to provide opportunities to develop excellence in scholarship. And every year they give out a small number of awards for professors in Ireland to come to Canada and professors in Canada to go to Ireland. And it's approximately two each per year. And these are very competitive awards, and Molly has done a fantastic job of actually obtaining one of these to be with us for a little period of time here in Montreal. And the one deal that they have to make here is that when you get one of these awards, you have to give the James Flaherty lecture. So this is the prerequisite as the very minimum that we have to achieve. Now, the program itself was actually financed by James Flaherty, who was obviously the finance minister here in Canada, and someone who has very strong Irish roots. So what I wanted to do is just highlight James Flaherty a little bit, because obviously he's a very important figure to us too. So most people knew him as Jim Flaherty. That was the name that he sort of went by. And for those that didn't know, he is actually a Montrealer. So he was born in Lachine in 1949. He studied at Loyola High School, so just a stone's throw from the Loyola campus, where my office is based. He was a very, very keen hockey player, shockingly. Man from Montreal being a keen hockey player. So much so that he actually won a scholarship to Princeton to study sociology, where he graduated cum laude. But then, as most sociologists, went off and became a lawyer by doing a law degree at York. Yeah, I know, very random. And spent about 20 years being a lawyer, incredibly successful lawyer. He was a partner in two different companies, one that still exists today. But obviously what most people know Jim Flaherty for is the work that he did in politics. And he was first elected into the Ontario provincial legislature, thank you, in 1995. And then he was there for 10 years. And then was elected in 2006, in January 2006, to be the representative for Whitby in Ontario, and became a member of the Canadian Parliament. And very quickly, became finance minister. So within a month of being elected, was actually then appointed finance minister by Stephen Harper, which was probably the smartest move that Stephen Harper ever made. Because I think pretty much independent of where your political background is, I think it's fair to say that Jim Flaherty was probably the cornerstone as to why Canada managed to survive the recession, where most other countries really desperately struggled. Obviously it hit us all, but Canada was least impacted. But of course, one other thing that he was also famous for as finance minister, and that was actually getting rid of the penny, which was a pretty smart move because it cost us a penny and 1.6 pence to make, compared to the actual cent that it was valued was. Unfortunately, as most of you probably know, Jim Flaherty actually passed away not long after retiring from being finance minister in April 2014. And he is the last person to have had a state funeral in Canada, and quite rightly so. But one last fact about Jim Flaherty that I wanted to just highlight very briefly, and that was actually in 2012, he was given an honorary degree by NUI Galway, which is the institute that Molly is at, in law. So Obviously, very, very strong links with Canada and Ireland, and an absolutely fantastic person. One of the things that in many, many commentaries that came out around Jim Flaherty as the person, there's two things that really personified him, and that was his sort of dogged determination and strong work ethic. Beautifully sort of summarized by this quote from one of his colleagues. You know, he's a driven person, certainly is prepared to do what is necessary in terms of time and hard work to achieve what he believes is right. And I thought this was a great quote because I think it not only applies to Jim Flaherty, but also applies to Professor Molly Byrne, who is our speaker today. And I've known Molly for just over a year, and I've always been constantly impressed with those facets of the person that she is. So Molly is a health psychologist. She did her undergraduate training in psychology at Trinity College Dublin, then moved to Galway and did her master's, PhD, and then never left. Is still there. She's director of the Health Behaviour Change Research Group, NUI Galway. She's a Health Research Board she holds the Health Research Board Research Leadership Award. That's a lot of research in one word, one sentence, which is an incredibly prestigious award to hold. There's very few of them in Ireland and very few within the field of psychology. I mean, it's mostly people that are working in medicine specifically. Her research areas sort of span understanding and developing behavioural interventions, and then taking those interventions and implementing them so that actually healthcare gets better. She is, of course, as well an avid tweeter, so I do thoroughly encourage everybody to take photos during the talk and please tweet them. Molly Byrne, IRE. That's a pretty easy one to remember. And without further ado, I am now going to hand over to our main event, Professor Molly Byrne.
Alors, bonsoir, mesdames et messieurs. Je suis très contente d'être ici pour this James Flaherty lecture. Merci beaucoup pour tout le monde qui m'a aidé à être ici. Malheureusement, maintenant, ou peut-être heureusement, je vais parler en anglais parce que mon français n'est pas assez bon. Mais merci à tous pour parler avec moi en français. So good evening, everybody. Thank you very much, Simon, Kim, for a very generous and a warm welcome. I'm delighted to be here for this James Flaherty Visiting Professor lecture. As Simon says, the minimum requirement of the award, so it's good to have this box ticked. And I just want to thank everybody who has been involved in organising, so particularly Simon Bacon and Kim Lavoie and all their colleagues in the Montreal Behavioural Medicine Centre and as part of the International Behavioural Trials Network. And a particular thanks to Concordia School of Irish Studies and the Faculty of Arts and Science who very kindly have hosted and organised this event. So basically, the theme I'm going to present on, as Kim very generously said, I suppose is one key theme which really has become more and more prominent for me as I have come through already 20 years of research in this area. And it's the area of strengthening research through public and patient engagement. Now, I have to say, I was actually at a conference in Quebec City last week of a group called Knowledge Translation Canada. This is, if you're interested in this area, I certainly would recommend you check out this organisation. But I did get a little bit scared at this conference because basically they are talking about very advanced levels of engaging community, engaging research users in their research and in their practice. And I did think, oh my God, I'm going to speak to people in Montreal on Tuesday evening and pretend I'm some kind of an expert in this area. So I am a little sheepish in terms of speaking to a Canadian audience in these kinds of topics, because I do actually think Canada is probably ahead of the posse in this area. So hopefully there will be something useful, novel and of interest to you as part of the talk. So particularly delighted to be here in Montreal. As Simon said, I visited Montreal for the first time in May of last year when Simon Bacon and Kim Lavoie had organised a conference of the first conference of the International Behavioural Trials Network. And I landed into a city which was in full bloom with the blossoms, 23 degrees, fully functioning public transport system, bikes, and I just thought, wow, and speaking French. So I thought it was just some combination. So I was absolutely delighted to get this award. So I have 10 weeks in total in Canada. So I have 8 weeks of that here in Montreal, and then a week in Ottawa and a week in Halifax. So the main chunk of it really is here. And I'll tell you a little bit more about what I'm doing during that time as we move on. But just before we move on, we might do a little bit of a who's who quiz as a little nod to where this lecture is actually happening. Anybody know? Quiet now at the back. Anybody know who this is in this picture? Very good, very good. So James Joyce, very significant Irish literary figure, and his wife Nora Barnacle. And I suppose I'm showing this picture primarily because being hosted here in the School of Irish Studies, I think you have one of the leading Canadian Joyce scholars here heading up the school, so it's particularly good symmetry. And I suppose also because we have recently celebrated Bloomsday, which was the date I was due to be born, and therefore I'm called after Molly Bloom, who was basically based on Joyce. The character was based on Joyce's wife, Nora Barnacle. So I contemplated a little reading from Molly Bloom's soliloquy, which is the final chapter of Ulysses. I cannot claim that I have read this book, but I have read the soliloquy. But I thought it just wouldn't quite set the tone for the lecture. I don't know, are any of you familiar with it? But I think the key message is yes to all sorts of pleasure. And I thought that a Montreal audience wouldn't really actually need much convincing about that. So for our next who's who, Jim Flaherty, yeah. Do you know who he's with? No. It's not a very flattering photo of her, in fairness. Nobody recognise her? So Mary McAleese, the 8th President of Ireland, was President of Ireland between 1997 and 2011. So this photo was taken actually 10 years ago tomorrow. Anybody guess at what event these two people might have met around 2007? So basically this was taken at the opening of the Ireland Park. Let me make sure I have that name right. The Ireland Park, which is a park, a waterside park in Toronto, I suppose marking how Toronto received nearly 40,000 Irish immigrants in the early part of the 20th century, people who were arriving starving, very unwell, bringing a lot of sickness. And I suppose it's very moving, I think, as a human being, but particularly as an Irish person, to read stories of these people coming in that state, making that journey and arriving into a place like Toronto and being welcomed. I mean, I'm sure they were not totally welcomed. It's hard to believe that, you know, shiploads of thousands of very unwell people would have been welcomed, but apparently they were welcomed and they were incorporated into Canadian society. And I suppose just as an Irish person, thankfully we're fortunate, much more fortunate now in terms of the circumstances of coming to Canada, but I have to say I've had an outstanding welcome to Montreal, so you're very, thank you to all of you for this warm welcome. So, for those of you now who are perhaps geographically challenged, and I have to admit, I'm sure if I was from Montreal, I would be kind of hazy on the details of where Galway is. So this is Ireland, and then Galway is here in the west of Ireland, so it's a city on the coast. And Simon kind of hinted at, you know, I arrived to Galway and then did my master's and my PhD, and I'm still there. So Galway has the enviable reputation in Ireland of being a city which is called the graveyard of ambition. So before you get to Galway, basically, you may have fabulous ambitions to be leading scholar, fabulous artist, wonderful, you know, international musician, but when you basically get to Galway, your ambition is, I want to stay in Galway. So I have a few photos here just to do a little kind of plug for Bord Fáilte. I mean, without wanting to be too over the top, I suspect Galway probably is to Ireland what Montreal seems to be to Canada. So in the summer, there's rarely a day that there's not a festival going on. So you can see our beautiful, on the right there, Macnas, who you might actually be familiar with, parade. So when the weekend we arrived actually to Montreal, we were here for the Les Géantes. And I mean, it's just like, I mean, a Macnas parade in Galway. I suppose I have to admit what Galway does have that Montreal doesn't have is that beautiful sea. So my children were very keen that the one thing that you might actually know about Galway is this video, which is Ed Sheeran's Galway Girl. So this is Saoirse Ronan twirling around. I think she came to Galway for one day to film it. And apparently it's got like 1 million or 1 billion or 1 trillion views or whatever on YouTube. So it seems to be probably doing more for Galway than Bord Fáilte has ever managed to do before. So it was within this city then that I'm currently living. I'm based within the National University of Ireland, Galway. So as Simon said, I'm a health psychologist, and all my research and teaching has been with health professionals, and I suppose primarily with the aim of promoting health, achieving better health outcomes. And I was very fortunate that in 2013 I received an award from our Health Research Board, who are our national research funders. So it was one of 6 awards, and these awards were really given to address identified gaps in health research. And one gap that I had identified was capacity around applying behavioural science to developing, evaluating and implementing behavioural interventions. So as you'll all be familiar, lay and people working in this area, most of the chronic illnesses and the health issues with which we are currently dealing with in our modern society are chronic illnesses which are largely determined through behavioural predictors. So this was the focus of my award. This is our lovely quad here, and there's our quite nice, actually modern, newly built School of Psychology up there in the top right. So our vision here in the group then, really we wanted to lead the agenda looking at behavioural science and its application to impacting on health. So our bread and butter is that we're interested in developing and evaluating interventions to promote health. So these are interventions which might be in a public health setting, so looking at preventing chronic illness, or in health services settings. So we're running projects which are in primary care and in secondary care, hospital-based studies. So we also wanted to, as I liked Kim, I can't remember exactly how you phrased it, but you did say something which did reassure me in the introduction of that this had a flavour of science, which I think is just absolutely spot on of the kind of work that we do. But we really do, one of our aims is that we want to advance the science of behaviour change. And critically develop methodologies which can be used in this area. And I suppose one of the main aims then of the Research Leaders Award was around building capacity. So this is about developing training, so some of the initiatives that we run is we run twice a year we run a workshop looking at designing effective interventions. We run a regular monthly seminar, and I mean if you're interested you can go online and look at the kind of activities we're involved in. So this slide really just gives you an overview of, now there's a lot of acronyms and stuff there, but what I'm hoping to do in this is just to show you that the core people funded by the Health Research Board Research Leaders Award are those 4 people in the middle. But then we've managed to link in with a large number of other projects. So these are in areas such as looking at developing sexual counselling and assessment and cardiac rehab. So I suppose that's primarily an intervention where we're trying to change health professionals' behaviour. Looking at an intervention about trying to increase hand hygiene within hospital services. So this is very much a kind of an organisational level intervention or study. At the very bottom there, the ICE study is looking at trying to increase or improve infant feeding interactions in primary care, so interactions between general practitioners and parents of young children, specifically looking at transition feeding, so looking at weaning from breastfeeding to solids. So this gives you a kind of a good span of the type of research. I suppose particularly important for what led to this visit here to Montreal was the work that I do, just in terms of those two people up at the top, Professor Andrew Murphy, who's a professor of primary care, and Professor Declan Devan, who's a professor of nursing. But they're both leading initiatives, so the Primary Care Clinical Trials Network, and then Declan's running the Health Research Board Trials Methodology Research Network. So I'm closely linked with both of these groups, and I suppose what these have in common is that they're interested in the methodology of trials, and I'm aware this is a diverse audience, so I suppose a trial in this context really just means a study where we're looking to see if an intervention is effective in comparison to no intervention. But there's a whole, as you can imagine, there's a whole science out there in terms of how these trials are conducted. So it was probably February last year when I stumbled upon the International Behavioural Trials Network, just happened to see it online, and it just struck me as such a fantastic idea. So this is an initiative which has been up and running now for, I'd say, about 3 years, being led by Professor Simon Bacon and Professor Kim Lavoie within the Montreal Behavioural Medicine Centre. And basically the remit here is to try and facilitate international links, efficiency of international collaboration between people interested in doing behavioural trials, hopefully resulting in higher quality of trials, and generally looking to develop a programme of research that will promote this quality of trials. So this was the main focus of my James Flaherty Award, which was looking at what we've just started, is a research prioritisation activity to see to try and develop a consensus around a research agenda for this network. So I think that's a fabulous photo there of the Montreal Behavioural Medicine Centre. So that was the first time that I was here in Montreal, and that's kind of my main link for the award. But I suppose to get on to the real substance of what I'm looking to talk about, I suppose I have been working in this area of doing research, trying to improve health outcomes for 15, 16, 17 years. And like any of you who are aware of this research in the audience, you will be aware that there is very significant waste in terms of investment in this research. We're all familiar with the policy documents that sit on shelves. We're all familiar with the papers that are never read. So some of the problems are that the research is not relevant. It's not implemented, so you might find something fabulous, but it's not possible to implement it. It's not measuring what matters, so you may have made some very significant improvement to some biological marker that actually people with a condition are not really actually motivated to change. It's not impacting on health. It's not transparent. And it's unaccountable. So these are the list of some of the problems which are inherent in health research. And there's a brilliant, actually that reference there is from a brilliant series of papers in The Lancet, which is one of the leading medical journals, which discusses the problems and tries to present some solutions to health research and some of the issues. So obviously these problems are very to the fore of the minds of people in the Canadian Institutes of Health Research and the Health Research Board, and I've no doubt research funders all around the world. And one of the potential strategies which has been suggested by these boards to try and overcome some of these problems is to try and increase patient engagement. Health Research Board in Ireland, we more commonly call this public and patient involvement. So there's a kind of a phrase of PPI. But you might be familiar with other terms such as user involvement, user engagement, citizen engagement. I think it just depends on what the actual topic of your research is, who it makes most sense for. I think user engagement is actually it's not terribly, it doesn't travel very well, but I think essentially in terms of capturing what this is about, I think user engagement really works. So as I said before, I think the Canadian Institutes of Health Research are really kind of leading the way in this area. So I think these are now considered, as far as I can see anyway, internationally accepted definitions of patient engagement. So I suppose essentially what we're talking about is when patients really collaborate in the research. So they're involved in the governance, priority setting and conduct of research, as well as in the dissemination and the use and the implementation of the research findings. This second quote then as well, I think really emphasizes some of the benefits from engaging citizens and engaging patients in research. And I like this final bit of that the international experience is that if you're engaging citizens, it's much more likely to be effective if you do so from the very outset. So it's not that you start your project, you have the project going, and then you think, oh, here are my findings, I'll get some citizens engaged and disseminate. So I think one of the key messages is that you get people engaged early on. So this is the model which is provided by the Canadian Institutes of Health Research around patient engagement. Now, you needn't get too bogged down in the text there, but I suppose what this is really just saying is that it's putting patients in the centre. So this is very much specifically talking about patient engagement. It's putting the patients at the centre and looking at how researchers, health professionals and policymakers can work with patients. So they're suggesting that they may be interested in identifying research priorities, identifying what patients value, and then working with the patients to actually conduct the research. So I'm just flagging this model because I will show you a couple of examples that I'm going to talk about. I will just show you how they're set into that model. So for the rest of the time, I'm going to talk very briefly about three examples of projects that I've been involved in that I have used these types of strategies. The first one is a project where we worked with end users, so it was actually patients, health professionals and policymakers to identify research priorities and work with us to develop a research agenda. In the second one, I'm going to talk about a project where we worked with again, patients, health professionals and policymakers to identify what is important in terms of outcomes from a research study. And then finally, I'm going to give you an example of a study where I feel, and it's actually a study I'm actually very proud to be involved in because it's been the most satisfying project I've ever been involved in. It's actually a project that I really feel, yeah, this is actually working. And this is a study looking at developing what we call our D1 Now intervention. And it's an intervention looking at promoting self-management among young adults with type 1 diabetes. So I'm only going to give you a very brief flavour of these to try and emphasise, I suppose, some of the methods that we've used and the strategies that we've used. I'm not going to get bogged down in some of the detail. But I suppose just to couch it, all of these studies are in the area of diabetes. So just to give you a very brief background in terms of diabetes, possibly many of you are already familiar that diabetes is a very rapidly growing chronic illness. So currently 1 in 11 people are going to develop diabetes. So I suppose the two most common forms are type 1 diabetes and type 2 diabetes. So about 10% of the population might have type 1 diabetes. So this is the diabetes that you're born with. But still there are a lot of behavioural aspects that you need to do if you have type 1 diabetes to safely manage your diabetes. Type 2 diabetes then, I suppose, is a condition that really just brings behaviour absolutely to the fore because it is a condition which is about 90% of the people with diabetes will have type 2 diabetes. So I suppose if diabetes is not properly managed, it can result in some very serious side effects. So I suppose it's a condition that management is extremely important and central. So you're probably familiar with some of the risk factors for diabetes. There are also risk factors for cardiovascular disease, for some cancers. So I suppose looking at diet, physical inactivity, and then I suppose some of the key actions there. So these are World Health Organization slides just in terms of key actions required. So it's very much around administering insulin as required, managing your diet, maintaining your weight and being physically active. So these are the central behavioural features, and I just thought I'd just give you a little bit of an overview of that before we start into the studies. So this one around research priorities. So basically this, I think, fits very much within this kind of left-hand side of the model of providing input on identifying health research priorities. So I suppose the rationale here really is that if you want to study what's important, you really need to find that out from a range of different people. So I think it is about getting the right things to study, but I think there also is a really key bit which is about the process of the research. So it's not only what you end up with, it's the process that you have engaged these people from the outset of your research. So this was one of the first things we did when we set up the Health Behaviour Change Research Group. We wanted to use a kind of a consensus and a consultancy approach in terms of developing what we were going to look at, because it was one of these awards that was actually an amazing privilege, because I had a little bit of a blank card, really, 5 years, go and build capacity and do something useful in this. So really what we aimed to do here was to identify 2 behaviours that we would develop interventions in. And we wanted it to be a behaviour relevant to people with diabetes and a behaviour relevant to healthcare professionals. So this gives you just a very brief overview of the process that we use. So in advance of this, we recruited our participants, and I'll show you a few more details in a minute about who they were. Our participants online generated all the behaviours that they thought might be relevant to do research in relation to diabetes. We then brought them in for a research prioritisation meeting where we presented back a long list of all the behaviours that had been suggested in the first phase of the research, and we asked them to rank how important people found these target behaviours. And we then took their scores together, and then we fed back their scores to them there and then in the room, and we allowed people to discuss. We encouraged, I suppose this is a consensus process. So the aim of this is that you're getting people's views, you're allowing a discussion to take place, and then you're getting people to give their views again in terms of how important they think it is. So I suppose the aim here is that you're moving towards more of a consensus, as for example, a person might say, well, I actually think active travel to school for children is obviously the most important research focus. And somebody else might say, well, absolutely not. It's how they attend their primary care appointments or whatever it is. So we moved towards, we had a second ranking then within the group, and then we calculated those final scores, and we were able to produce then what this process had developed as the priority behaviours. So this is just a photo of the room. We had, I think it's 24 people in total there, so we had a range of healthcare professionals. Hard to get people in policy, but we did have a few of them. And we did have 6 patients in total, 3 people with type 1 diabetes and 3 people with type 2 diabetes, who were recruited through our national organisation for people, support group for people with diabetes. So in terms of the research priorities identified, we identified really 2 leading ones. So for patients, we identified that attending and engaging with structured education was the primary and most important identified behaviour for patients. And this was across the board, that was for type 2 diabetes. And then for type 1 diabetes, actually focusing on trying to engage in collaborative treatment goal setting was the behaviour identified for both healthcare professionals and patients as being the most important. So these 2 research priorities were then used to develop projects within the group. So this is Milu Friedrichs, a PhD student who's working on the goal setting project, and this just gives you a very brief overview. So Milu has just completed a systematic review of goal setting as a strategy in terms of behaviour change interventions. And then she's going to be working with a self-management program called Daphne, which is a self-management program delivered in hospitals for people with type 1 diabetes, and it has a goal-setting component. And Milu is working with people within those programs to see how it's currently delivered and potentially how it could be improved. So Jenny McSharry, who is actually visiting Montreal next week, she's currently at the Global Implementation Consortium maybe in Toronto, a conference there. So it's certainly, as we say in the group, it's the year of Canada. There's quite a few others kind of lurking around in different places as well. But So Jenny is looking specifically at a qualitative study where she's speaking with healthcare professionals and people who have attended and not attended this structured education. So basically international evidence is that anybody with type 2 diabetes should be attending this type of structured education. And the attendance rates, now I don't actually have any of these figures for Canada. We don't have them for Ireland as well. We're kind of light on data in Ireland. But certainly in England, where you would maybe expect it to be a little bit better, I mean, you've percentages like 2 and 3% of people who should be attending these programs actually attending. So it's a very serious problem actually within diabetes. So Jenny has just completed actually conducting this qualitative study. So she's conducted interviews, as I say, with patients and educators. And I suppose one of them is a very simplistic presentation of the results, but I suppose one of the key messages that we have heard from people with diabetes is that they take a lot of cues from the message given by their health professional. So if the nurse, if the GP, if the hospital doctor does not really say, oh, you absolutely need to attend this program, it's really important, it's going to be really useful, they think, well, hell, why would I take a week off work? You know, they don't sound like they're very convinced by it. So I suppose that's one of the key things that emerged from Jenny's work. So at the end of each of the 3 examples, I'm just going to take a little pause just to talk about some of the things that we found good and bad about the process. So I suppose one of the beautiful things about doing this is that when you work with people to develop research priorities, so we have Margaret Humphreys, who is the current leader in Ireland of structured education programs, and she's got this responsibility to develop these programs in Ireland. She's there in the room talking about how important this is, and then we decide, okay, we've all agreed this is important, we'll do some research. It's then so easy to do the research, because I suppose of any of you who have experience of doing research, my first kind of proper research job was doing a study of frequent attenders to an emergency department in a very hardcore inner city Dublin hospital. And one of the brilliant things about the study was that it was around the clock. So, you know, I had shifts sitting in the emergency department between midnight and 6 in the morning. And it was the classic researcher thing of, you know, going up and, please, will you answer my questionnaire? So, you know, the researcher's life, there's a lot of time spent kind of begging people to do stuff. And the beauty of this is that that was completely removed, because you have people engaged from the outset, and it feels really good, because you actually feel then as a researcher, I'm doing something that you have told me you want done. And that's a great starting point. I think particularly people who are experienced in research will really empathise with what a relief that might be. And then policymakers are engaged from the outset. And I suppose the key thing here is trying to keep people engaged throughout, so that they can be involved in how you present the results. They will help you in terms of disseminating the results to the right audiences. And it's a great justification for funding. So when you're writing perhaps that research grant application and you're saying, well, why would you want to do this research? You say, well, I didn't just think up. It's not that I thought, oh, wouldn't this be a great thing to do? I've actually gone through a systematic process to identify these. So I suppose on some of the kind of negative sides, I suppose this was the first kind of these consensus group studies that I had run with both healthcare professionals, policymakers, researchers, and patients involved. And I suppose, to be honest, going back, I would not do it in the same way, because I felt we had a lot had a little bit of initial discussion, so people with the conditions, people with diabetes, that come along, we'd had a little bit of a discussion in advance of the meeting, but basically I was there chairing the meeting and I needed to get all these things done. So if you're in a professional context, it's easy for me to say, okay, Simon, that's enough, you've made your point, we'll move on now to whoever. But if Simon's there as somebody, as a person who has just been diagnosed with type 2 diabetes or whatever it is, and is coming along because he feels rightly so, I've been asked along for them to get my view, he's going to tell his story from his personal perspective, perhaps, of what it means to him to have type 2 diabetes. So I have to say I found this very challenging, the meeting, and if I were to run it again, I would either have the patients and the other stakeholders separate, or I would put a lot more work into the patients, into meeting and the process of working with the patients before the consensus group. And then I suppose the challenge for our group, and the challenge I think for people doing work in this area, is how you then keep people involved. So this is a lovely structured process that people get involved in, but then you kind of start inviting them to half-yearly meetings, and they kind of think, well, why, what specifically are we going to do, you know, and there mightn't be something so structured, and it might be harder for them to keep them engaged. So the second study then is a study that we looked at trying to identify a core outcome set, and I'll define that in a minute, for young adults with type 1 diabetes. So I suppose young adults with type 1 diabetes are a particularly interesting group because they're transitioning from, I suppose, having had a chronic illness through most of them through quite a long duration of their childhood, where largely their condition might have been managed by parents, by hospital services, and then obviously they're transitioning to independence. So things are changing for them. They have been identified as a particularly high-risk group with very poor health outcomes. So I suppose a very important group to try and support in terms of developing better self-management. And I suppose this little picture on the right is really just to show you that for most young adults with type 1 diabetes, their condition, their chronic illness is just one of a lot of other things that's going on in their lives as they transition to independence. So I was part of a European group about 3 years ago who came together, or people who were working in this area of young adults with type 1 diabetes. And one of the real needs that we identified through the kind of first meeting that we had in that group is that we currently don't know what are the most important outcomes to measure in terms of developing interventions in this particular setting. So there's a whole international movement around developing core outcome sets. Now really all this means is a group of outcomes which are recommended to be measured as important outcomes in either trials, so in either intervention studies, testing interventions, or in some settings in clinical practice. Now I suppose there's a whole movement associated with this. And I suppose one of the key things is that in line with the kind of patient engagement focus of today's lecture is that the inclusion of key stakeholders is really essential to this process. So it's not just sitting the same old people down and getting them to decide what are the important outcomes. Very much looking at the range of stakeholders, the people with the condition, the people working with people in the condition. So this is the international movement is called the COMET Initiative. So they have a really good website actually, and you can see a list, they have a library or a whole list of all the core outcome set studies that are currently being done. So our aim then was to use an international eDelphi consensus study, so another consensus type approach to identify these core outcomes for young adults with type 1 diabetes, and that is Anthony O'Connell over there to the right, who was the research assistant on the project. So very briefly, our method was we had just conducted a systematic review, which has now been published, of interventions trying to improve self-management among young adults with type 1 diabetes. And through all of those studies, we created a kind of a long list of 87 outcomes. We then conducted a two-phase eDelphi survey. So we really surveyed these stakeholders here, who included people with diabetes, young adults with diabetes, and health professionals and policymakers from all the international countries that the international team represented, and got them to rate how important they thought each of the outcomes that was listed was. We had a final consensus meeting then with 12 people to identify a final core outcome set. So this meeting was very interesting, and this meeting worked much better than the research prioritisation meeting that I talked about previously. One of the key things as well was the number of people. There were 12 people in this meeting. It's much more manageable. There were about 24, 25 in the research prioritisation. It's just actually, it's too many to get kind of good, meaningful discussion going. So here what we were doing was we were presenting, so we basically chucked away, we threw away all the outcomes that everybody agreed were not really important. we kept in a little box all the outcomes that people had really agreed were very important. So these were in the online survey. And then the ones we were really interested in discussing at this meeting were the ones that there was a mix of agreement. Some people thought they were important, other people didn't. So again, a little bit like the process of the consensus meeting, there was discussion, there was re-ranking, discussion, and then a final voting. So this is a very standardized process. There's a guidelines paper which was published last year actually in terms of a methodology around identifying core outcome sets. So basically we identified 8 core outcomes which should be measured as a minimum in interventions in this particular area. So you can see there the number of people out of the total of 12 people voting that these should be included. So there were maybe, in terms of the voting, there was maybe another 20 that didn't make it into this core outcome set. And I suppose what's particularly interesting in this set is that, just to go back to this, I suppose some of you might be working in the area of diabetes, and if you are, you will be aware of how HbA1c, which is the main biological marker of how well somebody is managing their diabetes, is seen as the absolute holy grail. It's kind of all that matters in your study. Did you manage to change HbA1c? But I think what was very interesting, and actually not surprising based on work that I've done with people with diabetes in this, is that that wasn't what was. It's certainly in there, it's in the core outcome set, but it wasn't the thing that was really, everybody thought this is really important. So it was much more around the experience that people had of how much stress their condition was, their quality of life. And that's really not surprising, because those are the things that for any of us moving to a new place, dealing with a chronic illness, those are the things that really matter. But what's useful about this is that a systematic process has been used to engage people, and their voice has been heard and brought into that. So, in terms of future research in this area, I suppose what we've done is we've identified the core outcomes, but the future work that needs to be done is to identify the actual tools to measure those outcomes with. So again, just in terms of, I think, on the positive here is that I think these core outcome sets are very important. And I suppose the real aim is that if everybody who's researching interventions in any particular clinical area, in this situation for young adults with type 1 diabetes, if they're all using the same outcomes in their research, it allows us to synthesize the research, doing a systematic review where all the studies are using the same outcomes. I mean, that's quite a gift in terms of the ability to synthesize the evidence. And then I suppose just that those outcomes that are important to all stakeholders are included. So I said that this worked much better than the other research prioritization. And why this worked better is that we had trained public partners, if you like. And I'll tell you a little bit more in the final study about how we had young adults with type 1 diabetes who'd been trained as part of our developing a research young adult panel as part of research partners. So there's some questions around generalizability, the robustness of core outcome sets that I suppose aren't really so relevant to citizen engagement. So the final example then is this intervention study. So I just want to particularly acknowledge that guy in the middle with the tie, Sean Deneen, who's a professor of diabetes in NUI Galway, who has been a long-term collaborator of mine. Lisa Hines, who's lurking at the back, who was the behavioural science postdoc researcher, and Mary Claire O'Hara in the yellow dress, who was the project manager. And this group also includes a number of young adults with type 1 diabetes who were members of our young adult panel. So again, this is over on the kind of right-hand side of the model, which is about engaging citizens and public in the actual research. So in terms of, we were interested in developing an intervention to improve outcomes for young adults with type 1 diabetes. So for all the research that we do, we follow these systematic frameworks of developing, piloting and evaluating our interventions. So this is the UK Medical Research Council guidance for developing and evaluating complex interventions. So I suppose the work I'm talking about falls very much here within the first box, which is the development box of developing our intervention. Another framework that we use in terms of developing our interventions, I don't know are any of you familiar with it, but the Behaviour Change Wheel, which is a guide to designing interventions, which has been developed primarily by Susan Mickey in University College London. And I suppose what this does, what hadn't been done before, is it provides a really systematic approach to move from your theory of why a particular behaviour works. So you see in the middle you have COM-B, whether people have the capability, opportunity and motivation to change. So you develop your theory for the behaviour, and there's a systematic approach then to moving towards identifying your intervention functions. But basically I suppose the main focus here is that within this study we developed a young adult panel at the very outset of the research. So this is just the ad for getting people involved. This was an ad that was posted on some social media. It was put in the local paper. There were posters put up around the university, around the hospital. And I suppose what was very significant about developing this young adult panel was that we did it in collaboration with an organisation called Jigsaw. So Jigsaw is an Irish youth mental health promotion organisation who I think are totally ahead of the posse in terms of how they run their organisation in a really engaged way. So one of the examples I really love in terms of how engaged young adults are in terms of running Jigsaw is that they never recruit anyone into Jigsaw unless there's a member of the young adult panel on the recruitment board. And I just think that that really indicates that they're very serious about how the young adults are proper partners in how the organisation is run, and I think it has been hugely successful. So basically we were facilitated by Jigsaw. They shared their models with us. So our young adult panel members received training in research, so they were going to be part of our research steering committee. So we wanted to be sure that they knew some of the language we were going to use, that they were familiar with what our study aims were. So they were given a lot of prep in terms of being able to engage with us. They were also, they currently are quite involved in research dissemination, so they would be attending conferences. So they're involved in a number of different levels. So I suppose how they communicate with each other, and I suppose this is a central thing, that time really needs to be given, that the group gels. This is, they're there as a group, and it's very important that is facilitated. So they communicate in different ways using social media. So again, this is our process of systematically developing our intervention, and just that the young adult panel were involved in all of this. So for example, when we were doing our systematic review, members of the young adult panel assisted with us in reviewing some of the papers, assisted with us in writing up some of the papers. We had an event where we were engaging with technology, and I suppose this was a particularly nice synergy because I suppose young adults, I think an example is, we were going to send letters out to invite people to take part in the study, and the young adults just went, nobody reads letters, nobody gets letters, nobody reads letters. So, it was kind of through WhatsApp that we were setting up a WhatsApp account, and it was just we were assisted in properly communicating with them. And then I suppose the final stage of this project was, I suppose, a consultation forum, which was 2 days at the end of the project. And this was held in Galway, June of last year. Basically, that's the group there outside one of the doors in the quad. So for the first day, we had different experts from different areas that we were interested in: diabetes service delivery, self-management, digital technology, and then around engagement. And certainly one of the most moving aspects and one of the most effective aspects of this were presentations given by the young adults themselves, members of the young adult panel. And then day 2, we had a more structured approach, something a little bit akin to the consensus meetings that I talked about before, where we presented the evidence of what we'd found throughout the 2-year duration of our study to a range of different stakeholders and got them to work with us to really refine our intervention. We also ran in parallel a hackathon. Is anyone familiar with that term? Yeah? So this was actually, I'm really not interested in general in the technology per se, but this was really where a group of people got together The young adults just absolutely loved this. They just really got into this. And this is where you have computer scientists, you have engineers, and you have people with the actual problem. They're coming there with the problem. Maybe you techie guys know about these things, but that you put them all together and basically they brainstorm, they come with their different approaches and produce some kind of a result in terms of the intervention. So basically, I'll just skip forward to the intervention. I'm just conscious of time now. These are some of the shots. I have to say it was, and this is what I mean about it being one of the best projects I've ever worked on. There was something about having the people that the research was really relevant for, really involved, and saying, this is really important. So there was a real energy around the day, and I feel it worked really, really well. So I suppose throughout that process where we worked together, we have now developed an intervention which we've just been funded actually to run a pilot of. So it will be delivered within hospital young adult diabetes services. And I suppose the three core themes are that there will be a key worker. So I suppose one of the things really strongly identified by the young adults was if they don't really know anybody in the services, they're much less likely to attend. And attendance at structured education and for regular appointments, really, really critical. So I suppose the point of the key worker here is that it's somebody who's not medically trained, but somebody who will be their key link to work with them to access the services. There's going to be an interactive online system and a very much young adult-centred agenda setting component of the intervention. So I suppose just based on that, sorry, I'm jumping ahead there. Based on that, we have actually just been awarded a Health Research Board, so again, our research funders, Public and Patient Involvement Ignite Award. So Sean Deneen here is the PI on that award. And that award is awarded to the university. And basically, it is around developing capacity and expertise and infrastructure within the university to facilitate groups from all areas to be able to develop their expertise. So I must say, I think it's a very progressive initiative from our Health Research Board to develop capacity like this. So I suppose finally from that third example, I've talked about it being rewarding, it's easier to get people to participate. So if you're struggling to recruit people into your study, I would really encourage you to rethink your strategies for recruitment, because these young adults could recruit any number of young adults into the study. So, you know, whereas me going, dear, you know, or writing them a letter, that's even worse. I'm very confident that our intervention is going to be more implementable, more acceptable, and therefore more likely to be effective. And the funders love it. The Canadian Institutes for Health Research are going to love this stuff, and I know that the Health Research Board do as well. So, you know, it's important to feed into that as well. I think on the downside, certainly this, I suppose, is the most intense public or patient engagement project that I've been involved in. And there have been situations where you do feel a little bit of a, you know, I am a scientist, I'm a researcher, I want to get the process done. Yet there are other situations in which you can experience these conflicts and clashes because the young adult with type 1 diabetes is coming from a very different place. It's timely, it's costly, and it's not just an add-on. It's not, oh, we'll have a member on our steering committee who we'll invite once a year, because I've been involved in studies where we did that as well. And it was better than nothing, but it's a million miles away from this type of patient engagement, which really impacts on the outcome of the research. So what? So these are my final couple of slides, and I would encourage you, I suppose one of the things, and when we were putting together the application for the PPI Ignite Award for the Health Research Board, we had a few skeptics within the group who kept saying things like, but you know, what's the evidence that this stuff works? How do we know this improves the research? You know, is this not just creating an extra layer of complexity, of difficulty? And in a way, that person has a point, because the evidence about whether this improves the quality of the research is currently light. So this is a systematic review which was published in 2014, a really excellent review. And I suppose what they found in this is that there are a lot of qualitative measures there around the research that are definitely improved. So development of user-focused research objectives, the information, the questionnaires, the tools that are used. better recruitment. I mean, even for those of you who are struggling with, participant recruitment, that in and of itself is a really important aspect. And you have the user-focused, I prefer that than consumer-focused, user-focused interpretation of findings. So all of those are on the positive. I suppose on the negative side, and there was some discussion actually about the challenges at the Knowledge Translation Canada meeting last week as well. And I suppose these are a lot around the practical aspects, that it is costly and timely. You have to be willing to have meetings, 7 to 9 in the evening with your young adult panel, which may not be what you'd choose to do of a Tuesday night, although you actually have. I think one of the big discussion points last week was around the difficulty of recruiting diverse public and patient participants. So there is a risk of the young adults, for example, who participate in our young adult panel, of being the ones who were kind of in there anyway. They know the people in the centre. Now, I'm not saying that that's actually the case, but I think it's very hard to really get those really hard to reach people. And I think you have to be very creative, and I think you have to be very patient. And I think you have to really get out there to recruit people, if you really want a diverse perspective of the people who are actually going to be challenging in terms of the delivery of the service. And then there's some conflicts around, what we need to do as researchers and academics and what people with the condition need to do. So that is really it. I just want to acknowledge particularly the Ireland-Canada University Foundation for the privilege of having this award to visit Montreal. These are a lot of my collaborators, and I've already thanked Concordia for the great welcome, and I suppose particularly Simon Bacon, Kim Navois, and all at the Montreal Centre for Behavioural Medicine who've been very welcoming. Just before I finish, quick blatant plug of two events if you're looking to fill up your diaries for next year. So again, we have beautiful Galway, beautiful Montreal up here on the top. So the European Health Psychology Society Conference, which I must say is, well, it's a total staple of mine. But this year it's in fabulous Padova. But next year it's going to be Padova in Italy, but next year it's going to be in beautiful Galway. So if you're interested in that, it's a great conference to attend. If you're interested in health psychology and behavioural interventions, it's always a great conference. And then, of course, the second conference of the International Behavioural Trials Network, which will be here in Montreal, May 24th to the 26th. And I know plans are already afoot and are looking very good for that conference as well. So thank you very much, first of all, for coming along, and thanks for your attention. Thank you.
So we're going to take about 15 minutes or so for questions, if people have. And then afterwards, we are going to give you the wine and cheese that we promised, because obviously that's a very important aspect of this process as well. That's
a psychological experiment. You have to ask questions for 15 minutes before you get the wine.
That's it. And then, so there'll be opportunity to mingle and talk afterwards as well. So if you don't manage to get all the questions in that you have now, Molly will be here and the rest will be here. So we'll start at the front here.
Yeah. Okay. Thank you for your question. I'm actually just going to repeat the question for the camera here in the recording. So I think the question is very well made, and it is around the importance of accessibility, of people being able to be engaged in these kinds of activities. So there might be issues around poverty, around where people live, around maybe disability, around education levels. And to be honest, I think they are all really serious challenges to meaningful patient and public engagement in research. I think that we have kind of skimmed the top of the iceberg with this project, in that I think that we did attempt to get as diverse as possible group of young adults with type 1 diabetes involved in the project. We brought them in, we engaged with them in spaces that they usually hang out in, and we provided training. So we assumed that they had no background in research. So we provided initial training in terms of to try and get them up to speed in terms of what they would need to know for going into the project. I'm involved in another project which is looking at developing interventions for primary care around promoting healthy infant feeding. So I mentioned that briefly at the start, and a sub-part of that project is looking to try and engage people, particularly in very low income areas in Ireland, because I think around infant feeding, if you're looking at breastfeeding rates, they're just dramatically different in terms of if you've an educated, well-off population versus, I remember speaking to a public health nurse in a very deprived area in Dublin who had talked about out of 100 women who were on her kind of caseload who just had babies and she was doing health visits, she said out of that 100 women, 2 women were breastfeeding and neither of those were actually Irish. So I think that's a good example. So anyway, within that particular area, I think social background really matters. I think social background matters in all areas of health, but I think particularly in that there's still really diverse differences. So what we've tried to do is to recruit mothers through primary care centres in very low income areas. And it just takes, in that study, it has just taken more work. We've had to, for example, ensure that the children could be brought in to running the groups. So I suppose it's just to try and make allowances and facilitate, but I think your point is really well made, and I'm not claiming by any means that we've managed to crack some of those challenges, and I think you're right that I think that this is a very positive move, that there's more citizen engagement and research, but it can't just be more of the same. It does have to, I think diversity and being able to address diversity is really important in making it effective and in making it useful. Oh yeah, sorry. So the question is that I haven't told you about the studies or the interventions or the programs that I have been involved in that were successful. So I suppose what I've tried to do in this lecture is tell you of 3 examples of projects that I have been involved in. And I suppose these are all early phase research. So they're not actually testing, is this intervention effective yet? So I suppose for the final study of the intervention we've developed targeting young adults with type 1 diabetes, we're currently just moving to pilot that. So to see if it will be possible to implement it, whether it's going to be feasible and acceptable. So it's frustratingly slow, but down the road, hopefully we will be in a position to see if our intervention has been effective.
Thank you.
Yeah.
So we are, just to let people know, we are streaming live at this very moment, and we do have a question from the
Irish
those that
world.
are watching.
Okay.
Yeah. So actually, we have a number of questions. I'm just going to start with one. Going back to the project with the type 1 diabetes, did you actually use any methods to evaluate the engagement of the individuals?
Okay, so methods to evaluate the engagement. I'm not sure if this is quite answering that question, Simon, but we're currently it's actually been led by a colleague in NUI Galway, Sharon Conway, and she is conducting a qualitative study with members of the young adult panel. And I suppose the aim of that little kind of sub-study is to try and see what that experience was like, because our sense is that through engagement, the young adults on our young adult panel have benefited hugely. But we need to be able to get some evidence around that. So that is really the only thing that I can answer to that question. But I think that will show some very useful data to find out just the experience of engaging. Yeah, thank you, Kim. So that question is really, I suppose, from the perspective of the health professionals or others, isn't that it, and researchers in terms of how that community feels about engaging citizens in research. So my sense, and I mean this is not based on data, Kim, but my sense is that this is still complete minority stuff. And I suppose having worked through the application for the funding that we've just received within the university, there's a handful of people doing this stuff. And I do understand that I've certainly been in meetings where you have people with the condition, so patient representatives. And as a researcher, there's a total formula in terms of how we interact, how we proceed. We know exactly what we're looking to get out of a meeting. And then a patient comes in and throws a whole different thing, and they have something that they really just desperately want to say. And it's very important for them, but it can be very frustrating then for the research team. So I think there are definite challenges, and I think is certainly probably, I'd say hostility is probably too strong, but I'd say there are people who would not be seeking this stuff out. But I think that's going to change. I really think that's going to change. And I think it's about getting more effective methods. I think it's about mainstreaming it. Yeah, yeah. A great question, Kim. So that question is really primarily around the multidisciplinary approach and how, for example, a university might facilitate that required multidisciplinary approach. So, for example, to use departments such as film studies, other kind of arts. So I suppose I'll refer maybe to the application that we just got of the PPI Ignite, so Public and Patient Involvement Ignite Awards from the Health Research Board. And I suppose what I think was particularly good about these is that they are awards to the whole university. So what they were demanding of us was that it wasn't just the usual suspects of the health research community. We absolutely did go to our media and outreach office. We have a really active, actually, film studies department in NUI Galway. And we did engage with those in terms of, because it does require taking very different approaches. I mean, in health sciences, it's that formula of how we do our research, how we disseminate our findings. It's often terribly dry and terribly inaccessible for people. So there's huge opportunities, I think, to engage with other, particularly arts and humanities, and people who have some maybe marketing, people who have some expertise maybe in these different strategies to try and make our messages more interesting and attractive. So I think the cross-university approach to developing this is really important, because of course it's not just health research that this is relevant to. I think it's really relevant to all forms of research.
We have another online one, and we'll come to this, very, very simple one relatively. In the core outcomes data set development, did you include parents and their caregivers in the consensus exercise process?
So maybe young adults and their parents or carers, is
Yes.
that? Yeah. So no, I suppose our definition of young adults with type 1 diabetes are people who are aged 18 to 30. So really parents were not involved in that process. And I suppose even in terms of the young adult panel for our study, I mean, parents, of course, as an 18-year-old, 19-year-old, you're still very much involved with your parents, and for some of these people, parents might be giving them lifts to the place, but they're very much there as young adults. So no, we didn't engage parents in that process.
It's really exciting.
Yeah, I mean, it's... Yeah, absolutely. It would be really good to talk about that, because it does seem like there's a lot of synergies. And I really like your idea of kind of setting up the network and the infrastructure, which can be perhaps a support network, perhaps a means to communicate, and then can also be a springboard maybe for research projects. Whereas I suppose ours has been very much around our research project, which was brilliant, and we were delighted to get funded for that. But that sounds like, I mean, that to me is how all the health services should be set up.
Yeah, well, it's a nice age demographic because they do use social.
It's brilliant, yeah, it's brilliant.
It's harder to do that in
Yes,
diabetes.
exactly, yeah. No, it's great, thank you.
So I'm conscious of time, so I'm going to say Chair's prerogative to ask the last question.
Okay.
And then we'll have some refreshments. And that is, so you've been doing this now for a little while. You've had multiple different experiences. For the people of the audience, what do you think the biggest, so one or two take-home messages about, what is it? Why should we be doing this? Or, the real why. And,
no, it's a good one, Simon. And I suppose as a researcher, this type of research has been the research that I have felt. This is really actually going to make a difference. It's really, it sounds maybe a bit whatever, touchy-feely, but it is actually really touching the people who it matters to. Whereas I suppose because I'm not a clinician, I am a complete 100% researcher, which I love. I love doing research, but I'm very conscious that when you're doing applied research where you actually want to impact on health outcomes, I think this approach really is going to make the research more enjoyable, more doable. It's much easier to do it. It takes time and you need to set up the infrastructure. But I definitely think much more satisfying and much more likely to be ultimately effective. I think there's probably many people in the room who've gone through, you know, a study, maybe a randomized controlled trial of an intervention after, you know, a couple of million Canadian dollars investment, 5 years of research time to show no difference in outcomes, you know. And I mean, that's the problem that I kind of started off in the lecture of, just this waste of research funding. So that's my answer. Thank you, Simon.
Thank you very much. So I'm just going to close out by just doing a few thank yous, and I'm going to start at the bottom and work up. So I do want to acknowledge Kim Lavoie, who just walked back into the room, who co-directs the Montreal Behavioral Medicine Centre with myself and was integral in putting this application together. She's the Department of Psychology at UQAM. Concordia alumni, yes.
Sorry, Simon, I think you better.
Oh, there we go. Also, as well, obviously, the Montreal Behavioral Medicine Centre, for which I'm very grateful that a number of members turned up, including our fabulous staff and students who are strewn around the room, and patient partners as well, and the research centre that houses that. Concordia, the Faculty of Arts and Science, and Kim for primarily providing booze, but for actually, no. For actually coordinating all the aspects of this actual lecture and making this event happen. The School of Irish Studies for hosting us in this fantastic room. As Kim mentioned, I think everybody feels a little bit smarter as you walk into this room, just by virtue of being here. International Behavioural Trials Network, which is sort of this overarching entity that we've been trying to get off the ground and get some momentum on, which is a fantastic endeavour with a lot of people involved. The Ireland Canada University Foundation, obviously for funding this. And then finally, for Professor Molly Byrne, for giving the lecture. Thank you very much. There's one little thing I have to tell you very briefly. That is, it's actually Molly's birthday today. And as a birthday present, a sign of our thank you, just a little gift for you.
Thanks, Simon.
No
Thanks.
problem. And finally, I would like to thank the audience who have taken an evening off of their schedules to come and be with us, and for the questions that were generated. I hope you enjoyed it. I invite you all to relax for a little bit longer, grab a few nibbles, so there's something to drink. Molly's going to be around, so if you have questions you'd like to ask her, feel free to do so. Thank you very much.